Yeah, it has to be really very strong because what we make is the same as they made with the mosquito. Just going inside the canal, just checking with the finish of the cannula that we are just going underneath the retinaculum. We can feel the roughness of the retinaculum, and when, as Carla said, when we see that there is no resistance, the only thing we make is just to point it out, to make a little cut, 1 millimeter cut, just to put it out. So for us, it's really important just to have the cannula just inside, just to be sure that the cannula is in place, and when the cannula is in place, then we make the cut. So the systematic is the same one. You have to check after the proximal row between the scaphoid and the pisiform. And you see the entering is really not a problem because the retinaculum is really curved, and it's really not the way with the cannula just to go to the canal, because it always you put the cannula, the panel is going inside and very deep, because the retinaculum inserts just very deep to the pisiform. And the second one is just to check between the hook of the hamate and the hook of the hamate and the trapezium. You know, this is the only flat bone in the wrist that you are on the safe zone. You see the retinaculum is about 2 millimeters in the thickness, and you have a window of about 2 centimeters just to cut. It's really you don't have a problem distal, because the nerve is usually always, almost always, just outside the canal and just outside the hook of the hamate. So you have really not really problems just to put the cannula inside and to check if the cannula is correct. You can draw all, if you want, at the beginning, just a line, because the retinaculum ends really when we have no bone. This is the end of the retinaculum, because you lose the bone. So we know that we are now outside the canal, yes, because the retinaculum is just going from the bone to the bone. You can make, if you want to draw a line distal, just to know that when I put the tip of the cannula outside this line, I'm not really outside the canal. And as I said, the only thing is just to be sure that the cannula is just on the right position before you cut. This is the only difference. To point out the cannula is also interesting, just to check that we are always targeting the web space between the third and the fourth finger, because this is the correct direction. We have to make our incision just a little bit ulnar. You want to check it after?
We will check the release.
So also important is not to be too close to the distal crease, because you have to have some space just to put the cannula or your knife inside. The incision is 5 millimeters because the knife is 5 millimeters, so we have to have an incision that's really for the 5 millimeters that the knife has.
La pantalla.
So we make an opening. Usually we don't mark the opening, and we don't use also I use the transducer just to put my anesthesia, because I think the two most important things is just to have local anesthesia, and the local anesthesia not inside the canal. It has to be superficial, as Fernando told. It's really important because the patient has to have some sensitivity. And the second one is the cannula. Local anesthetic and cannula are the two main steps. We just make an opening ulnar to the palmaris longus. You can check with the patient. You make a mark. I don't use usually a needle inside the canal, and I make an opening 5 millimeters. I make a little bit longer here. The same as Fernando told, you have to use usually a scissor just to perforate the deep fascia. You know, you feel a pop just inside, and then you are inside. And then I take the cannula. It's not open. Now, yeah. I put the cannula inside. And I check from the beginning where my cannula is. You see the cannula, I have to go just underneath the retinaculum, and if I check that the entry point of the cannula is correct, you see the median nerve. Can you make it a little larger? Vamos a quitarle un poco profundidad.
No, este es el foco, no.
Pues dale más, ahí un poco más. Ahí, perfecto. I have to check that the cannula is just ulnarly to the nerve. You see the nerve. And then I put the cannula just in position. As I told you, it's really impossible just to go to the Guyon canal because it goes deep. So you have to stay on the middle, always checking that the cannula is underneath the retinaculum. You have to put the cannula. If you see I'm now underneath the retinaculum, you can check all of the way that you are ulnar to the nerve. The entry point is ulnar to the nerve. And now I'm inside the canal, and I can feel the roughness of the retinaculum. It's here not so good to feel.
It's very important. You have to feel that.
You have to feel. And usually, here is not so good to feel. When you are outside the line and outside the retinaculum, you have only to push outside, and you make a
stab incision in the skin.
Stab incision that we don't stitch after because it's really very, and the palmar arc in our dissections for our work for 15 years, we measured the distance between the distal part of the retinaculum and the palmar arc. It was about 1.5 centimeters. This is the widest distance for the structures at risk. Thinner branch was about 5 millimeters, but the distance to the palmar arch is really very big, and you don't have a problem with the palmar arch because of the curve of the cannula. This is why if we can put the cannula so, and if you can check, we make the second step to cut. But we have to be sure that the cannula is really correct in place. So we check again, the cannula is in place. You see the nerve, you see the cannula. We go down underneath the retinaculum, proximal row of the retinaculum, distal row of the retinaculum, cannula is in place, and now it goes up to the skin. Yeah? And now that we are sure that the cannula is in place, we make the cut. This is why we have to have a 5 millimeters, because the knife is 5 millimeters in there. And then you take no está todavía. You take the cannula as a rod just to cut. You can also control, because you see the cannula is 2 millimeters in the tip, and we cut usually 3 millimeters from the cannula to the surface. We have to check, márcalo si quieres, that the superficial point of the blade is just over the retinaculum. That embraced, the knife embraced the whole retinaculum. And then we make the cut.
As you see, we are in the short axis, and this part is without ultrasound, because the cannula is fixed, so we know we are in the right place.
Now we have cut the retinaculum, we have to check again. If the cannula is just all over the way as outside the retinaculum as here is. If you don't are sure, we make a second cut. But always letting the cannula in place. This is really very important. Not to go out and just put the cannula inside again. You have to be really sure. Vamos a hacer un segundo corte. You have to be really sure because there are sometimes some fibers of the thinner fascia, intertendal fascia, that remains. And we have to be sure that we have cut. At the beginning, we tried only to cut the retinaculum. Now we are going to cut all because we have seen some residues after. If you really don't cut really the whole structure, yes, you have to see that the cannula is going outside. You see here, you can have, I think it's really okay, but there are some places where can have doubt. With the cannula, you can cut it even more. It's really not a problem because the cannula is make sure that you don't have problem because the cannula is just moving superficial always at each cut.
Okay.
Okay.
No. We will see with the knife.
Okay.
So now we will view what we have done, and we will see in the endoscopic, because you will see when you are opening the carpal tunnel, as Javier says, the palmar fascia remains intact. Okay. So at the first view, you will see that I didn't cut the flexor retinaculum, but once you spread the fascia, you will see that indeed it's the flexor retinaculum cut, but the fascia is not, okay? And with that hypothesis, we thought that there were more strength in patients operated by ultrasound-guided surgery, but in the end, there is no difference in terms of strength. So now we perform the same procedure. We dilatate with this instrument the portal, and we will insert the center line, which has like a blade which is hidden inside the groove of the knife, and we have also a ruler to view how far we are going. So now we should arrive just to 5 centimeters, and let's see. This is the cut, flexor retinaculum. We have arrived. You see the cut? This fat, which is over 5 centimeters, is indeed it's you see the artery, arterial arch. I will go distally, okay, but now I am going back, and this is the cut of the retinaculum. This is the retinaculum cut. This is the retinaculum, your edge, and you see up. This is the fascia. You see the fascia, which is intact, it's not open. Maybe here, but the retinaculum, it's perfect. And if we move radially, this is the nerve here. Don't cut that. And this is the tendons. But it's a complete opening of the flexor retinaculum. So congratulations, Javier. You have done a good job. And
thank you.
Okay.
Okay.
Any doubts? Any comments? You wanna?